Are we in the right space? Okay, so here we are. So he has, I have a case right now. We're going to talk through, and I want you to think about this, right? So if you have a crush injury, right? This is crushed. Here's your DIP. Here is your, relax. I know where the PIP is. Like I'm not trying to guess. This is the PIP. This is the PIP. This is a DIP, and then here, right here, is your MP, right? So this is a crush injury. So what can potentially happen in a crush injury? You have to think it got smushed right here. So you can have a fracture. You can have obviously a lot of soft tissue damage, right? And you can have some obviously nerve involvement because the tip of the finger has a ton of nerve endings, right? So what can you anticipate if you have a fracture? That they would need surgery. You anticipate a lot of soft tissue damage. There's swelling, there's pain, there's a lot of nerve damage. Again, a lot of pain, very, very sensitive. Everyone who has a crush injury has very similar problems, right? Crush injury also can hurt the nail bed. So here's your nail bed, and if you don't fix the nail bed, then the nail can't grow properly. So in this case, it was fractured, right? They had to repair the nail bed. So the nail bed repair is very small. Oh, the other thing is you potentially could injure the terminal extensor tendon, right? So you can possibly damage tendon, which is just soft tissue. Tendons are soft tissue. So what other soft tissue can you damage? This can be torn. Then you have your flexor tendon. This is the profundus, and a lot of times the profundus is maybe not torn, but is really injured in the whole crush part of the soft tissue where there's edema and swelling and all that stuff. So when you have a pin, so if you have a fracture, you're gonna have a pin, right? So they call it an ORIF, but you're not really opening anything. It really should just be called a pinning. So what they're gonna do is they're gonna put a pin through the top of the finger, and they're gonna push it all the way through, down through the DIP. So what you're doing is you are stabilizing the distal phalanx and the proximal phalanx. So what happens is when you have a big old rod on here, it's not a big rod, it's just a small rod. You can have a pinning here. Now, majority of the time when you have a pinning, they don't just put one pin, they put two pins, right? It depends on the severity of the fracture. But most of the time, if they put two pins, it's to reduce any rotational type of problems. I believe in his case, he only had a one pin. So I think when I see only one pin, the one pin is for the terminal tendon, right? Because that was ruptured. So in the crush injury, it was torn. So they're going to put that pin through to keep the DIP from falling. The one pin might, majority of the time is for the fracture as well. So if they put one pin, I would think the fracture is not that complicated. Usually when you have a much bigger displacement of a fracture, or there's some kind of rotational forces to it, they're going to put two pins. If you think about a shish kebab, right? You think about putting a shish kebab, your meat and your vegetables on one skewer. When you go to flip it, everything turns, right? When you shish kebab something and you have two pins down it, it can't rotate, right? So when you go and you flip that shish kebab, on the barbecue, all the pieces stay in place and they don't rotate, and you're like, oh my God, So normally when you see two pins, that is more for a displaced fracture, like a very displaced fracture that's like rotated. So you'll see a pin like this, and then sometimes you see a pin like that. They're gonna have two pins now. But he only has one, so that makes me think already that it's a mild fracture, but that pin is for the terminal tendon. Okay? Anytime you have a crush injury, you have 2 pins. Okay, so anytime, so a lot of times, so you know, it'll be like this depending on the rotation, but it's good to know you have 2 pins. They're deep underneath, so what they do is they nail it in. So it can be, so they're probably it's like probably side by side, yeah? Your pins?
No.
One is, and the one is cross, like this.
Right.
Okay, so they cut it down. They cut it down because normally when they have a pin like that to the side, they'll oh, you have to send me the picture. I'd love to see it. So when they have the pin like that, majority of the time they'll leave the pin sticking out. They'll leave the pin sticking out. In this case, that doctor cut it all the way. So when he goes back in to take it out, he's gonna make a little incision. It's gonna look like a cross, like right there. Yeah, and wherever it is, that's where you know, they go in with pliers, and they're you know, they're gonna cut like that and wherever, and they're gonna go and they're find it, and then they just pull it out. It's kind of like with pliers. I mean, you know, when they talk about orthopedics, orthopedics are pretty much like carpenters of the body. Yeah. Plate and screw, hammer it in. Your finger's like a shish kebab. You know, so when you move, it doesn't rotate. So, but we have a lot of nerves here, so that's why it's just so painful. And when you can't move this, and then you can't move this, it messes up the whole function of your hand, and then makes everything painful to all the way up here, because all your muscles start in the elbow and come down. So he can't open, he can't close, but you become more painful because nothing is moving the way it's supposed to move. So you have a little bit of everything, right? So we have, you know, one pin or 2 pin. It's for the fracture. It's for the mallet finger, right? So if you have it going all the way down, right? What are you not allowed to move?
The DIP.
You're not allowed to move the DIP. That's it. That's the only thing you're not allowed to do, right? So, I mean, sort of, right? So you're not going to push. You have a pin there. You're not taking that finger. You're not pushing. You're not blocking. You're not saying, oh, move it. Like, none of that. What we're supposed to do is support here, and you hold it like this, and you bend the PIP. You have got to move the PIP. It has got to move. If it does not move, we're in trouble, right? If he's so painful and he can't move the whole, am I gonna, you know, push on it? I need to, a little bit. The great thing about his finger is that it's fully extended. The bad thing is it doesn't bend. The worst scenario is when it's a little bent, but it can't go straight. Yeah, you have to move it, but it's hard. But your finger looks good, because sometimes people come in and they're like bent like this, but they can't go straight. So right now he can go straight, he just can't bend it. It's better to have one and not the other versus to have both problems. Can't bend it and can't straighten, right? So he's got 1 out of 2. We're doing okay still, right? So the problem is that all the tendons move through. So it's through here, here, and here, and here. So nothing is moving well. So for the DIP part though, you are allowed to touch. You want to put some lotion on, and you need to touch the top of the finger. I don't care if the pin is there, but the pin is underneath the skin, so we are allowed to touch. Are you gonna push like that on top? No, because that's where the pin is. But you have to touch the skin. When you don't touch the skin becomes more and more sensitive, right? We've got to, so that's part of the desensitization. Keep your hand here. So you touch it, you rub it down. So from the sides, from the top, right? From the side, you put lotion there, and that's where the terminal tendon is. That's where the terminal. So you have to go across it. You have to go around it. So you have to work on the sides of the finger, and then the front and the bottom of the finger here. So you can go nice and smooth. So your pressure is rated. So it's going to be really light at first. If they can tolerate a little bit more, then you're going to apply a little bit more pressure. And this is just manual treatment for desensitization. for edema and for scarring, right? You're not even moving, right? So if you can get that pain down, then you can start to move it a little bit. I would move it from the MP first. MP first is passive range of motion. You want it to go all the way down, you want it to go all the way up. If someone's really tense and you're pushing, then it's going to hurt them more. So the key thing is that you've got to get them relaxed. So sometimes I'll hold the wrist and I'll hold the metacarpal to get them to relax, right? And all you do is you're holding the finger without bending the PIP, without bending the DIP, just to pull it up, pull it down. When you hold it and you pull the MP into extension, all the tendons are moving. So it's moving up and it's moving down. And then on this side, moving down is moving up. So you've got to move that. You've got to move that MP. He has a tendency to hold his finger out like this. So all of his hypothenar is, very painful. So you've got to like work to massage it, work to release the tension. And then the part is anyone with a hand problem is going to develop, or at risk for developing a trigger finger. So you've got to work and make sure that they don't develop a trigger finger, right? So you can work a whole across the palm. I'm going to hold it like across the palm, right? I'm going to hold it like this. Here, let me see. So I'm going to hold it like this, and I can work across the palm. I can keep him flexed in like this, and I can work across the palm like this. See his hands in my hand, right? Relax. You see his hands in my hand, and I'm supporting my wrist in a certain way. Right? And it's just because I need him to relax. If he can't relax, I'm not gonna get much work done. It's gonna hurt. He's in pain, but how relaxed you get him, right? So you work the keys, and then after that you can move the PIP, but you've got to do passive, because it's very hard for someone to move the PIP when the DIP doesn't move, right? So then they cramp up. So I know. So what you have to do is you have to hold them and you have to bend them. Hold them and just do a little bit of passive, right? And then on the fingers you can do whatever you want. So in this particular case, he's very tight here, here, and here. And then he's probably very tight and painful here because he's trying to move it, but he can't move it. So he's very tight here. So you can rate it. You can be a little bit more aggressive. This side, and this side, right? But why are you working on what you're working on, right? So I'm going to work here because I know that he can potentially develop a trigger finger. If I loosen him here and decrease the pain and decrease the tension and decrease the swelling, is going to allow him to bend further. All right, that's why I'm massaging here. If I'm going to work in this direction here, instead of just going for certain parts, I would put him, I want to shorten everything.
Yeah.
Right? And then I would work on all the fingers and then come down and all the way down. All the way down, because I want to effectively, because he's got wrist issues. Now, not everyone's going to have wrist issues. If they don't have wrist issues, then you don't have to worry about wrist issues, but you would start with that, and then it's hard for him to do hook fisting, right? Because one does, it's almost impossible to get him to move it. He can't move it, right? So you can passively push him into a hook fist. What you want to encourage is a straight fist.
I want to encourage also.
You want to encourage a straight fist, because right now he can't move the IP, so he can't go like this and he can't go like this, because both the fist and the hook fist requires DIP motion. So what's a fist position that doesn't require DIP? Is a straight fist, right? So all you're encouraging, all right, is to come down, come up, come down, come up, nice and easy. And then since he's someone who has a lot of wrist issues, then you can work on wrist. And then, once you are done doing the stuff, then you can do the active stuff of, getting his wrist, And then, stick their finger out like that, gonna throw off the whole alignment between the hyperplanar, and it actually will radiate all the way up, keeping everything on the side. So what we need to do is we need to encourage that small finger to just lay in a more natural position, which is adducted in, right? And that's what you start with. You know, have a new pinning. Once you then we can talk about progression of a pinning. But at the very beginning of the pinning, the most important thing is desensitization, scarring, and moving the PIPs and the MPs.
With the, because I was gonna have him do poly pellets.
You can try that, but I would almost tolerate it. So I'd almost, you know, I don't know if he would tolerate it, but you have to remove all the and you gotta wash it. You just gotta tolerate washing his hands and tolerate washing some of that off, so we can put cream and try to get all that eschar off, because I wouldn't want to put that in the poly pellets, right? Make it look nice and pretty before you put it in poly pellets. But I think it would be difficult for him, the poly pellets. You can barely tolerate your touch. I think poly pellets is going to be really difficult for him.